Congenital Anomalies of the Kidneys and Urinary Tract, CAKUT Summary. CAKUT represents a spectrum of structural malformations involving the kidneys and urinary tract, diagnosed predominantly in neonates and children. These anomalies result from disruptions in normal embryonic kidney and urinary tract development, influenced by genetic and environmental factors. Recognizing CAKUT is critical due to its significant contribution to pediatric end-stage renal disease, ESRD. Etiology, genetic factors, specific gene mutations affecting renal development. Environmental factors, in utero exposure to teratogens like ACE inhibitors or angiotensin II receptor blockers. Common forms of CAKUT: 1. Duplex collecting system, complete or incomplete duplication of the collecting system, potentially leading to vesicoureteral reflux, ureteral stricture, hydronephrosis, and UTIs. 2. Renal dysgenesis, renal agenesis, absence of one, unilateral or both, bilateral, leading to Potter sequence kidneys. Renal dysplasia, disorganized development resulting in non-functional kidney tissue presenting with cysts and excessive connective tissue. 3. Congenital solitary kidney, presence of a single functioning kidney, often compensatorily hypertrophic with increased risks of hypertension, renal insufficiency, and ESRD. Anomalies of kidney migration, horseshoe kidney, fusion of the lower poles of the kidneys, often caught on the inferior mesenteric artery during ascent, increasing the risk of complications like stones, hydronephrosis, and infections. Diagnostics, prenatal ultrasound, often identifies CAKUT during routine screenings. Postnatal ultrasound, essential for any child with a history of UTIs, especially under 24 months, to assess kidney and urinary tract structure. Voiding cystorethogram, for evaluating vesicoureteral reflux associated with CAKUT. MRI urography, advanced imaging for detailed anatomical assessment, especially in complex cases. Management. 1. Surveillance and monitoring. Regular follow-up with renal ultrasounds to monitor for complications such as hydronephrosis or progression to chronic kidney disease. 2. Surgical intervention, indicated for obstructive anomalies or severe vesicoureteral reflux to prevent renal damage. 3. Management of associated conditions, UTI prophylaxis in cases with high risk for recurrent infections, blood pressure monitoring and management due to increased risk of hypertension. 4. Multidisciplinary approach, involvement of pediatric nephrologists, urologists, and radiologists for comprehensive management. High yield points for specialists. Early detection of CAKUT through prenatal and postnatal ultrasound is vital for timely intervention and prevention of renal damage. Management strategies should be individualized based on the specific anomaly and its potential impact on kidney function. Long-term follow-up is crucial to monitor for the development of hypertension, renal insufficiency, and to ensure adequate growth and development in affected children. Educating families about the implications of CAKUT and potential long-term outcomes is essential for optimal care and surveillance. Clinical case, duplex collecting system in a pediatric patient. Patient information, age, 4 years, sex, female. Medical history, no significant past medical history, normal growth and development milestones, no previous hospital admissions. Presenting complaint. The patient was brought to the pediatric clinic by her parents due to recurrent urinary tract infections, UTIs, over the past year, with 3 documented episodes treated with antibiotics. Clinical examination, blood pressure, heart rate, respiratory rate, and temperature within normal limits for age. Physical exam, generally well-appearing child, no acute distress. Abdominal examination reveals no masses, organomegaly, or tenderness. Genitourinary exam normal without external anomalies. Investigations, urinalysis, positive for leukocytes and nitrites. Urine culture, grows E. coli sensitive to first-line antibiotics. Renal and bladder ultrasound reveals a complete duplex collecting system on the left side with no evidence of hydronephrosis or renal scarring. The right kidney and bladder appear normal. Differential diagnosis, duplex collecting system with associated vesicoureteral reflux, VUR, primary VUR without duplex system, anatomical abnormalities like ureterocele or ectopic ureter, diagnostic workup, voiding cystorethogram. Performed due to recurrent UTIs and ultrasound findings, revealing grade 2 VUR into the lower pole moiety of the duplex left kidney. DMSA renal scan to assess for renal scarring, showing no evidence of scarring or differential function loss. Diagnosis: duplex collecting system of the left kidney with associated grade 2 vesicorenal reflux into the lower pole moiety. Management plan: 1. Prophylactic antibiotics. Low-dose antibiotic prophylaxis to prevent recurrent UTIs while preserving renal function. 2. Urological consultation. Referral to pediatric urology for evaluation of the need for surgical intervention given the recurrent UTIs and duplex system. 3. Surgical considerations. Potential ureteral reimplantation to correct VUR, with decision-making based on the child's age, degree of reflux, and clinical presentation. 4. Follow-up. Regular follow-up visits every 6 months with repeat renal ultrasounds and VCUG as needed to monitor for resolution of VUR and changes in the duplex system. Monitor for UTI symptoms and manage promptly. 5. Patient and parent education. Educate about the importance of adherence to prophylactic antibiotics and the signs of UTIs. Discuss the potential need for future surgical intervention and the rationale behind it. Discussion points: the significance of identifying anatomical causes of recurrent UTIs in pediatric patients to prevent renal damage. The management approach for duplex collecting systems, focusing on surveillance and minimally invasive management when possible. The role of prophylactic antibiotics in managing VUR associated with duplex collecting systems, and the criteria for considering surgical correction. Follow-up: the patient is scheduled for a 6-month follow-up visit with repeat imaging and a review of UTI symptoms and antibiotic adherence. Parents are provided with contact information for early reporting of UTI symptoms.